Perfect. Welcome back from the lunch break. So I'd like to introduce the moderator of the scientific session or the abstract session. So please meet Dr. or Professor Ulrika Ådén. She's a neonatologist and a professor in neonatology here with us at Karolinska and also in Linköping a bit, right? Yes. Welcome, Ulrika.
Thank you so much, Agnes, and thank you both Agnes and Stina and the organizing committee. It's a pleasure to be here. It's a wonderful conference. It's been so inspiring during the morning. I'm not exactly a skin-to-skin researcher, but I'm interested in baby brain development, and I look at skin-to-skin as the first parent-child interaction promoting experience and the foundation of the continuous interaction between parent and child, and which is so important for baby brain development. And we all know that socioeconomic factors are so important for babies' cognitive development, but skin to skin is free, so that's fantastic. Having been brought up as a neonatologist with Björn at Danderyd and others, it's a really natural part of neonatology, as for many of us in Sweden. And I think we are obliged to the midwife-led care that we have a history of in Sweden. I think that could be a key factor to implementing skin care globally. This session is about how to implement it in the smallest and the sickest babies, the parental perceptions of this, and the breastfeeding support. And we are excited that we had many abstracts submitted, and we have selected 7 of them, most from Sweden, but 2 from the UK and 1 from the US. Let's see now, it's the 13th. Our first speaker will be pre-recorded from Imperial College, UK, Aniko Deierl, a consultant neonatologist and PhD, and the title of the talk is Delivery Room Cuddle for Extremely Preterm Infants. And for the Q&A afterwards, the colleague Jayanta Banarje, also consultant neonatologist, will attend the session. So please.
Good afternoon. It is a pleasure to join you at this conference today and to share our experiences about implementing delivery room cuddles as part of standard care for our preterm infants in our units in London. Parental mental health is a huge issue in our neonatal units and following the neonatal journey, and we can quote several different research conducted, but I will quote the Bliss research published in 2018 following a survey in all 4 nations in the UK, where 80% of the parents said that their mental health suffered after their neonatal experience. And if we dig a bit deeper, actually 35% of the parents reported that their mental health was significantly impacted after the time of the neonatal unit. And it was up to 30% of the parents who actually walked away or been discharged from a neonatal unit with a diagnosis of a mental health disorder, either postnatal depression or PTSD, following the neonatal journey. So what is really causing this long-term significant mental health problem? There's no question that the trauma of the prolonged separation will have a crucial role in this. Feeling loss of control and feeling helpless at the cot side while the baby is undergoing intensive care, which will lead to issues with attachment, and potentially that the psychosocial support we are providing on the neonatal unit may not always be adequate for all the families. So how can we help? In our team, we are convinced that facilitating early physical contact in the delivery room is a good way to reduce the trauma of the separation. And we also have a very strong basis of family integrated care in our units. So when we started delivery room cuddles, We had a hypothesis that this visual and physical contact in the delivery room can facilitate early parent-infant interaction and reduce the trauma of separation. So we're going to talk about our concept and journey and our research about the mother's experience. So we started to offer delivery room cuddles from 2018, and this became standard of care in 2019 after developing a standard operating procedure and agreeing on certain safety criteria, working with our perinatal teams. So in our opinion, all babies awaiting admission to the neonatal unit should be offered a delivery room cuddle with parents before transfer to the neonatal unit unless the safety criteria are not met. And if a baby is born very premature, less than 30 weeks, this will be supervised by a consultant neonatologist, and particular attention will be paid if the baby is on NIV to maintain the CPAP seal during the cuddles. These are the safety criteria, what we agreed and what we are using at the present. And it's important to highlight that we do not use any gestational age or birth weight cutoff. So if these safety criteria are met, we will offer this to 22-weeker infants or babies who have a birth weight less than 500 grams as well. It's important that we prepare appropriately for this cuddle, and this needs to be communicated to the parents in advance and needs to be communicated to all the perinatal team members, providing care for the mother and the baby. And we will use the setup of the transport incubator along next to the mother to provide respiratory support and monitoring for the infants during the delivery room cuddle. We will pay attention to transfer the baby appropriately, as we would do when we're doing skin to skin on the unit as well. And nurses are fine trained, and so we will ensure that the baby is contained in an aligned position, and the vestibular input will be slow and linear, and we will aim to maintain the head position at the midline during the cuddle. We have done a piece of work about safety of the delivery room cuddles, so looked into 99 families who initially experienced delivery room cuddles and compared this to historical controls. And we assessed temperature, accidental exacerbations, changes in respiratory support, and time of admission to the neonatal unit. And we could not see that there was any increased risk of hypothermia for babies experiencing delivery room cuddle. And also the majority of the babies were still admitted to the neonatal unit within the first 1 hour of life. We also conducted a qualitative research by collecting feedback from the mothers via emotional mapping, and we tried to identify touch points which are significant areas of engagement to focus on during their delivery room cuddle experience. If you would like to know more, then please see the full publication, which you can download with the QR code. So using a descriptive qualitative approach, we conducted semi-structured interviews for 6 mothers. Their gestational age was 24 to 29 weeks. And the interviews were transcribed and then analyzed using thematic analysis. And the experiences revealed 5 themes, which indicated the key touch points of their experience in the delivery room or theater. So the first touch point was fears and hope around the time of delivery. Mothers had an intuitive sense of concern. They felt positivity from reassurance from the maternity and neonatal team. They all expressed feeling unprepared and having questions around the possible outcome, or hoping that the delivery actually will not happen and contractions are settling. This was followed by recognizing uncertainty, worrying the baby and preparing for the worst, and accepting that the delivery will happen. Again, finding reassurance and information useful, and valuing any choice around the time of delivery. And this was followed by the cuddle itself, which we identified as reclaiming normalcy. So all mothers reported that this experience was the only moments of feeling normality, and it helped them to mitigate panic and fear. They all explained that this was a surreal experience, what it helped them subsequently to form connections. So the delivery room cuddles were really the first moment of the family connection, the first moments where mothers could feel like a mother, and they felt that this empowering them and strengthening the parent-infant relationship for the journey ahead in the neonatal unit, empowering them for the parental role, while they were recognizing the future uncertainties through the journey of the neonatal intensive care. So in our conclusion, we felt that, or we feel that delivery room cuddles for preterm babies can safely included to the stabilization process at any gestation, based on our experiences at a tertiary perinatal center. And in our study, all mothers reported positive emotions about the cuddle with their baby, and mothers highlighted that this early physical contact was often the only positive and normal birth experience they could recall from the time of delivery. Implementing delivery room cuddles will require a culture change from all the perinatal teams and good communication and teamwork to execute this safely. And we're not saying that this is perfect. You know, we wish that we can do this without the plastic bag and without any textile barrier or towels around, and we can do this for an extensive, longer period for parents. But at least we are proud that we achieved this as standard of care, that this is offered to all families and infants, including the most vulnerable, extremely preterm infants as well. And we know that this is not offered everywhere across the globe as standard of care. So probably can be a starting point to offer this early contact and then move on to a more prolonged and proper skin to skin. Thank you for your attention.
Thank you so much, Dr. Deierl. And I believe that now we have Dr. Brimdyr here. Is that true?
I think I managed to be here myself.
Oh, you're yourself, okay. I thought I recognized you. Okay, that's great. So we have one question for you here. Thank you for your presentation. Can you please show your slide of safety criteria again?
I was not prepared to show slides during the Q&A. I'm on a different computer, but I can tell you it's mostly timely stabilization, so that the stabilization happens mostly within the first 20 minutes. FiO oxygen requirement less than 40%, and normal temperature at the time of the stabilization. So just as we kind of be moving to a continuous temperature measurement from spot measurements, but at least we have a normal temperature above 36 degrees at least to go ahead with the cuddle, and the availability and the stability of the mother. So these are the safety criteria that we are using, and these are consistent. So since we started to implement this as standard care, we have not changed our safety criteria. I think we have made exceptions when it was only the FiO2 potentially higher than 40%, particularly at the kind of gestation age 22 to 24 weeks, that if the other safety criteria were okay, we still sometimes went ahead to do the cuddle.
Thank you. Any questions from the audience? I have a question which I think you may be able to reflect shortly on. So this it differs. The cuddle differs a bit from skin to skin care. So could you just reflect on what are the differences and how you reasoned when choosing the cuddle?
Yes, I think from the beginning we were very cautious not to call it skin to skin, because we do understand that skin to skin needs to be bar skin on bar skin, and especially for the tiny babies we will have the plastic bag as a barrier, and we felt that at this point this was important because to ensure that thermal stability is achieved in that population. And sometimes we also have a towel around the baby, so because it's not direct skin to skin contact, we were always naming it as a cuddle, but it still achieve some physical contact and the mother actually seeing and touching the baby closely and having some time together prior to shifting the baby to the NICU.
Thank you so much. That was clarifying. So thank you for a great presentation, and we will move on to our next speaker.
Thank you.
Thank you.
Thank you for inviting.
Our next speaker is Siri Lilliesköld. She's a specialist nurse here at Karolinska and a PhD student at Karolinska Institutet. And the title of your talk is Parents' Experiences of Immediate Skin-to-Skin Contact with their preterm infant. Please, Siri.
Ulrika. Yes, so I'm going to hold a short presentation on a qualitative study addressing parents' experiences of immediate skin-to-skin contact after the birth of their very preterm infants. And I want to acknowledge my co-authors as well on this slide, so Sofia Svedberg, Agnes Linnér, and Rebelo Jonas. How do I work this? It's just yeah. So the immediate postpartum period has been described as a unique and sensitive period for both for adaptations and behaviors in parents and newborns. Being in skin-to-skin contact supports the infant's transition at birth, facilitates breastfeeding and parent-infant bonding. For the infant born preterm, this is a time period that most often involves separation, as we know, and benefits also for the smaller and yet not stabilized infants and parents at birth is a knowledge gap that currently is being explored. So the immediate parent-infant skin study, EPISTOS, is a multi-centered randomized controlled trial on very preterm infants born between 28 to 32 plus 6 weeks of gestation that were cared for in skin-to-skin contact immediately after birth and continuously for the first 6 hours and compared to standard care, which was in an incubator. And this is a study that we have conducted in Sweden and in Norway. And one of the questions that we ask in this study is if immediate skin-to-skin contact benefits parents and the early parent-infant relationship after very preterm birth. So in this qualitative study, the aim was to explore parents' experiences of immediate skin-to-skin contact with their very preterm infant, as well as their perceptions regarding care and support from the staff. We interviewed 12 parents. This was 6 mothers and 6 fathers who had all co-cared for their very preterm infant immediately and continuously for these first 6 hours after birth. And we analyzed these interviews using reflexive thematic analysis. So really looking for like patterns of meaning across the data set. And this is a study that has been published. Okay, so from the analysis, 3 themes were constructed that together formed a synthesis of the purpose, so the why, the conditions, the what, and the means, the how, for understanding and supporting skin-to-skin contact between parents and the very preterm infants at birth, which is displayed in the figure in the middle. So in the first theme, a pathway to connectedness, skin-to-skin contact enabled parents to actively participate and feel significant immediately from birth. Parenthood and early interactions were strengthened by the calming physical sensations of directly feeling and seeing their newborn and experience a strong need to be close. Ultimately, this built confidence in themselves as parents and was an experience that no one would have want to have been without. At the same time, as described in the second theme, when providing skin-to-skin contact at birth, parents spoke of themselves from a position of vulnerability. This related both to physical and mental readiness for skin-to-skin contact, as well as their ability to be present in the moment together with their newborn when in skin-to-skin, so relating more to an inner state. This could be impaired by the various challenges that parents were facing at the time around birth, as well as how they were met and understood by the healthcare staff. As the focus of both staff and parents naturally oriented towards the infant's needs during these first hours after birth, parents needed help maintaining a sense of being a person with own needs, rather than just becoming a tool for skin-to-skin contact. A shared element was the total loss of control that came with the preterm birth, and how parents were thrown into a new reality, which they really were struggling to understand and adhere to. And in this new reality, parents navigated towards forming a relationship with staff, which was based on trust. So ultimately providing them with a safe base to be with their newborn and skin-to-skin contact birth. And this support was mediated through staff behaviors and providing the parent with a sense of availability. Okay, so from the first theme, one parent said, let's see if we get that there. It was the first I saw. It was the first I got on my body, his whole body, when he relaxed on my chest. Then it became a completely different situation and a completely different feeling in my body. Then I thought, okay, this is my son. And from the second theme, I was in pain and it became hard. And then I felt stressed that he was lying there and that I could not have the right control over him. So I think that had it not been so problematic to get the placenta out, I would have felt even better than it did right then, because I could not focus on him. And in the third theme, so that when you get him on your chest, you can feel that they don't leave you. They might have gone away a bit, but then they peek in their heads and like, how's it going? So you still feel like you have a little, that you're doing something yourself too. So in conclusion, immediate skin-to-skin contact at birth was a valuable and empowering experience for parents, enhancing early connectedness and bonding, yet should be recognized as an interactive process with challenges and requires adequate support. A good relationship with nursing staff facilitates skin-to-skin contact. And these findings can be used to enhance staff awareness for parental needs, both in maternal and neonatal settings, when being implemented for very preterm infants at birth. And with that, I want to say thank you. Let's see if I get this slide on to show also. Thank you. The Pista stream. Okay, thank you.
Thank you, Siri. Let's see, do we have any questions in the room? So let me start then. Was there anything in your findings that you didn't expect?
I don't know so much what I expected or not, but I think that the first theme came across as very strong and very convincing, that this was really something that was very valuable for the parents and really helped them sort of attain their role as the central caregiver from the very beginning. But I think it's also very evident in for me as a nurse, at least in the theme 2 and 3, I think are very interesting. But it helps us think about how we can be understand the parent in the situation and sort of setting this these first postpartum hours as quite special, a special time, which might differ from other times in their NICU stay, and how we can be mindful of how we can support them and meet them in these first hours post-birth.
Yes, Ola, please. Do we have a mic for you?
Thank you, Ola Andersson from Lund from Malmö, Sweden. I was wondering, Siri, because it's being prepared and to be vulnerable, did you interview both parents that got, gave birth very suddenly because of a placental abruption, or those that has perhaps been being, admitted for several weeks. I would imagine there would be different experience.
I mean, generally in the Pistos sort of cohort of parents, most parents were more or less prepared. I would say yes. Quite few we like catch just like the ones coming in and just giving birth of various reasons. But so yes. But I would still say that these parents, even though in this material there are some parents that had spent weeks before giving birth, and some that had not, but still they spoke of not being prepared. I mean, it was like that was really a quite central element for, I would say, still for all these parents, that they really were not prepared for what to come. So yeah, I think that's just my response to that.
Short question, last question.
Björn from Sweden. Were there any things that make you feel that we could actually harm the parents if we do it without correct nursing around them? I mean, is it dangerous with this immediate skin-to-skin from a parental mental aspect?
From the parents' perspective now, yeah, because that's what, there's nothing in this material that's like in any way signaled harm. It was more like asking to be understood and met in this, what I have called vulnerability, and more being met and supported in that. And in that is this element of being seen as a person with own needs and being addressed as the person, so that not everything is just going through the infant. Also, when we speak to the parent, that we're just not addressing, the infant and the infant's need, and that we're also addressing the parent. So that was, so I think it's more that element. Yes.
Mother newborn couple.
Yes, exactly. Yes, thank you.
Thank you, Siri. And our next speaker is Emilia Biskop-Lindgren. And you are a midwife. And I think that, as I said, midwife-led births are really crucial for skin-to-skin care implementation. And you're also a PhD student at Uppsala University. And you're going to talk about to feel abandoned in an insecure situation, on parents' experiences of separation from their newborn being COVID-19 positive. So we didn't have separation for all newborn children in Sweden, but for some, and you have studied them. Yeah. So please, Emilia.
Thank you. Dear colleagues, I'm honored and humbled to be here today to present our latest study in my project in front of this competent audience. I would like to give a special thanks to the organization committee for having me here today. The coronavirus generated a global pandemic. Guidelines and recommendations for the care of infected mothers and their newborns varied between countries, within countries, and over time. The Swedish guidelines recommend that newborns and infected mothers are to be cared for together unless neonatal CPR or care at the NICU is expected. Then the newborn is to be separated from the mother. Our purpose of this study was to investigate parents' experiences of separation from their newborn due to the global pandemic from a Swedish context. We interviewed 11 parents who had been separated from their newborn child due to COVID-19. Our results show that having a deputy parent present with the newborn during the separation was considered helpful, and that the deputy parent was there just for the newborn, as the staff could have many other patients to attend to. Communication during the separation could consist of phone calls, video calls, photographs, and exchange of information. Parents described that the newborn recognized their voice if they were talking via phone or video call, which was described as emotional and important. If parents felt that they were being listened to and could have a say in the care of the newborn, it helped them to feel a sense of control and involvement. Parents also mentioned that receiving pictures or video calls did not help them in understanding how big the newborn was getting. Instead, they wished they could see the newborn through a window. Previous experience of being admitted to the NICU was a factor that improved some parents' well-being. It was also beneficial if the parents could meet the staff that cared for the newborn before the separation occurred. Parents expressed that putting the well-being of the newborn firsthand helped them to accept the situation. The separation was undesired, but it would have been even worse to stay together with the risk of infecting the newborn. The parents stated that hope and faith were what helped them through the situation. Parents with a religious belief mentioned that the faith was empowering. The parents were deprived of early contact with the newborn, and they expressed grief about losing this opportunity. Several parents did not even get to see their newborn before being separated. They felt sad over missing the newborn's first moments in life, such as the first bath or first skin-to-skin contact. During the separation, parents experienced constant anxiety and were stressed about both their newborns and their own well-being, as they were infected with a potentially deadly virus. The concerns varied from fear that the newborn would not survive to thoughts that the newborn would forget or not recognize his or her parents. The parents described difficulties in feeling like a parent during the separation, and they lost all trust in themselves as parents as a result. As one parent said, "It hurt so much inside because he wasn't close. Then, after a couple of days, it was like he had been cut off. And after 3 or 4 days, it felt like I didn't even have a child anymore." Even if things turned all right in the end, the parents expressed that they had wished for a different situation. They found themselves in an unwanted situation that they couldn't change. Parents expressed a need to feel prepared before being reunited. This could consist of practical preparations, such as being able to express breast milk or an exchange of information with the staff to prepare oneself before the reunion. The information could relate to routines regarding the newborn, such as when to feed the baby or how to provide comfort when he or she was upset. Parents described the newborn as unfamiliar to them when they were reunited, and some expressed being distressed even 1 year after the separation. Some talked about the separation as an experience that will stay with them for the rest of their lives. Because of the separation, the parents lacked basic practical parenting skills. Physical closeness to the newborn was viewed as favorable when overcoming this problem. Our take-home messages are that if a separation between newborns and parents cannot be avoided, parents need to be prepared and provided transparent information prior to the separation, during the separation, and before the reunion. Well thought out policies must be in place to decrease the impact of the separation on both the parents and the infant. Finally, parents should be able to have a deputy parent present during an undecided but necessary separation from their newborn. I would like to end with a quote from a parent. "Sometimes it feels like you can focus more on the individual and think that this is our life and our experiences. This we will carry with us for the rest of our lives." Thank you all for listening.
Thank you so much. Brilliant presentation. questions as I can see here. You, Stina.
Hello. Did you do some kind of survey to see how routines were in different units in Sweden? And did you find differences in how we cared for these families, these babies and these mothers? And were there units having isolation rooms where they could care for the whole family?
We have not done any kind of evaluation of that, but we've heard that parents have been treated differently in different units.
Hello, Ulrika from NICU of Huddinge, Karolinska. Did you see any difference if the mother could give her breast milk continuously in the parents' experience?
We have not asked about that, but I'm only speculating. But I think it's better if they could give the breast milk. Yeah.
I think it's great if we can learn something from this experience, so that we have plans for next time, as you say. But I'm sure you have read other papers on how this was perceived in countries where they had a separation in all families. So does it differ? Does their experiences differ?
I don't really know, but I think the differences are different regarding to routines at the NICU.
And I was thinking about how it feels for the parents, because if you are part of a big group that everyone is treated the same, then I don't know, I'm speculating it could be easier or worse, I don't know. But.
Yeah. I had one parent that said that she'd read, it was later on in the pandemic, and she mentioned that in retrospect she think that the separation was correct, but now she didn't. If she had given birth at that moment, she wouldn't have accepted separation.
Thank you.
Thank you.
Thank you. So our next speaker is pre-recorded, and it's senior specialist nurses Anna Rebelo and Colli Franzone from Imperial College, UK, on a parent-led transfer for skin-to-skin contact, a quality improvement initiative.
Hello and welcome to our presentation on skin-to-skin parent-led transfer. We are 3 neonatal nurses working at Imperial College Healthcare NHS Trust in London. We are a neonatal service composed of a level 2 unit in St Mary's Hospital and a level 3 in Queen Charlotte and Chelsea Hospital. To give a little bit of background, the definition of skin-to-skin contact, also known as kangaroo care, consists of placing a naked baby with a nappy on the parent's bare chest, covered with a blanket. This practice is recommended by the World Health Organization as routine care for all preterm or low birth weight infants. Therefore, awareness on the appropriate execution of skin-to-skin contact is crucial for healthcare professionals and parents. Research has also shown how skin-to-skin contact has many benefits for the physiological stability in preterm babies, but also for parents by reducing stress and help bonding and increase milk supplies. Skin-to-skin is also important in the family integrated care approach promoted in our unit. These are the reasons for our quality improvement project. The aim of our quality improvement project are identify current practice on the unit, assess enablers and barriers of skin-to-skin contact, promote and increase numbers of parent-led transfer for skin-to-skin contact. The methodology we used is a 3 weeks data collection, reviewing the time of skin-to-skin contact received on both units daily, a survey on staff knowledge and experience of skin-to-skin contact training, and then the creation of skin-to-skin videos and QR codes to share in both units for staff members. From the data collection we've done, you can see on this graph that most of the babies are having skin-to-skin for 1 to 2 hours. And from this group, only 13% are having it for more than 2 hours. Also, the type of transfer most used in our units is the staff-led transfer. Only 28% of the transfers are parent-led. From the staff survey, what has been shown to be one of the main enablers for skin-to-skin is staff training on this subject. For this reason, we've decided to create teaching videos for staff demonstrating parent-led transfers. And then from this, we've created QR codes to share them within the unit. The research we've done to support the QR project show that there is very strong evidence of the benefits of skin-to-skin, not only for the babies, but also for the parents. In the data analysis, we've concluded that there is room for improvement on the duration time of skin-to-skin. In conclusion, education and training are required to support the skin-to-skin transfers, specifically parent-led transfer, securely and using a developmental care approach. The next steps of our project are staff simulation training, audits, to understand if the video we implemented was effective, share these QR codes with the parents. As you can see in this slide, there is the poster we're going to use in our units to share the video. And also celebrate the Kangaroo Care Awareness Day, which is happening on the 15th of May. These are our references. Thank you for your attention. We would like to leave you with a quote from Maya Angelou. Do the best you can until you know better, and then when you know better, do better. Thank you.
Thank you.
Thank you so much. That was a brilliant presentation. And happy to see that you are online now. For the questions, let me start. I think you mentioned the barriers for skin-to-skin care, but what are the barriers in your unit? Have you identified them?
Hello. To start, thank you so much for the opportunity to be here. We also identified the barriers for our staff, which are the medical status of the baby was the most important one, obviously, if the baby is well enough to come out for skin-to-skin. But also the fact that the parents are not on the unit. Some parents, they don't come to the unit every day. And there was another one, which is being short of staff, which does not happen every shift, but I think it's not only in our unit, it's something that happened in other units. We've been short of staff, and then that is one of the barriers for skin-to-skin parents. I don't know if my colleagues have something to add on this one.
Hi everyone, my name is Daniela. I would just add that staff knowledge was also a barrier that we were able to identify. For the purpose of our presentation, we were not able to share everything, but we were able to identify that as well.
Thank you. I think we have a question in the Mentimeter here on can the parents stay in the unit? That's the question.
Yes, they can stay in the unit 24 hours. And then we have also parents' room. Not for all the parents, but yes, they can stay in the unit. Both mother and father, yes. Both parents.
Great. So are you planning to evaluate your implementation work? How are you doing that?
So as part of our next steps, we will do another staff questionnaire. So we will need to do more staff simulation training and also at bedside training and also an e-learning with the videos we've done. And after that, we'll do some more audits and questionnaires to understand what we need to implement more and what has been happening in the unit.
Great.
And just one more thing to add. We want to understand what are the parents' feedback and feelings about this as well. So we will be adding that on next steps as well. Thank you, Anna.
Very good. Thank you so much for a great presentation, and thanks for joining. Our next speaker is Pyrola Bäcke, a registered nurse and PhD student in Uppsala. And you are going to talk about the staff's attitude towards parents-infant closeness and routines during therapeutic hypothermia. So a very important patient group, I think, where we sort of induce separation with our treatment. So please, Pyrola.
Thank you, and thank you very much for accepting our abstract, and thank you for introducing me, Ulrika. This study is a mapping study that aimed to investigate the NICU staff's attitudes toward parent-infant closeness and routines during therapeutic hypothermia. Nope. There we go. So after 36 or more gestational weeks, most parents look forward to an uncomplicated and joyful, but however, maybe painful and exhausting experience giving birth to their baby. For some, this instead will be the reality. Annually in Sweden, 300 to 500 newborn babies is affected by birth asphyxia, and around 100 severe enough to qualify to receive TH, the standard treatment for these babies, which has shown reduced rate of death and neurodevelopment impairment in survivors. We know that separation is a source of stress for both the parents and infants during neonatal intensive care, and the TH periods represents a particular challenge since skin-to-skin contact clearly is not possible due to the thermal management principle. Therefore, we were interested in studying NICU staff's attitudes towards infant closeness and routines during TH in Swedish NICUs. So at first, we identified which Swedish NICUs in Sweden who had the TH equipment, which were 22, and out of these 22, 10 provided the entire treatment at their unit, and all 10 participated in this study. And here you can see the centers. And during 2021, 122 infants were cooled in Sweden, but the numbers of infants receiving TH at each included NICU varied from 0 to 33. From each unit, one neonatologist and one registered nurse participated, and there was a questionnaire with 70 questions and an interview that we made. So data was statistically analyzed and the qualitative content analyzed. And here is one example where you can see the family integrated practices at all the included NICUs. So you can see that the parents were allowed to be present during transportation in 5 out of 10. Skin to skin were conducted before the start of TH at 3 out of 10. A parental bed was placed by the infant's place at 6 out of 10. Siblings and parents were allowed to stay 24/7 at the NICU at all units. Parental presence during medical round, 8 out of 10. Parental presence during care procedures, 7 out of 10. Care procedures performed in parents' arm or parental bed, 1 out of 10, and parents were offered to revisit the NICU after discharge, 4 out of 10. And the interviews were analyzed with qualitative content analysis, and we found 3 categories. You can see here. The first, the importance of standard routines. The staff described that the importance of standardized routines and procedures regarding the preparation of the infant's care space and how the care should be conducted for infants. Established routines were time efficient and staff saving, which also freed up time to focus on the families. And here's one quote to illustrate that. You can sort of put your eyes on the family because you know that everything else just works. So I guess it's a matter of experience and routines that you can feel relaxed considering those things. And the second one, the influence of care environmental on parent-infant closeness. The staff also stated that the NICU environment affected parent-infant closeness and presence. Furnishing with a parental bed instead of a crib had a positive effect promoting closeness, encouraged the parents present and creating a better condition for the family to be together. And here is another quote. It gives a signal to the parent that here's the idea that you should be, next to your infant, close to your infant. I think this is a signal that the parent is a part of the infant's place of care. And the last one, practice around parent-infant closeness and involvement in care. All units were keen to encourage and support the parents to be actively involved in the infant's care. And here we have, the closer they are to the care place, the more natural the information that the parent received about the care process also becomes. They see what we do and they hear what we say in a different way. So enabling parent-infant closeness and presence during the stay at the NICU is important, and the TH period is not an exception. This study found that conditions can promote or curb the possibilities for parent-infant closeness and presence. Standardized routines regarding the care space setup, medical and caring approach, the NICU environment and practices around the families, and the attitudes regarding parents' role and capacity. So clear structure with room for flexibility regarding the family's need is therefore needed. Thank you so much.
Thank you, Pyrola. Great presentation. So, no questions in the room at the moment, but I was wondering, do you think that your survey has changed the attitudes in some units?
I'm not sure, but I think our goal was to also work maybe as an eye-opener and start a discussion that some things that you maybe thought was undoable at your unit maybe is doable, just to be asked the questions about it. So I hope that the question has inspired in other units to maybe think a little bit more than 3 days of treatment, and then we can start with the closeness work. It has to start from the very beginning.
Exactly. And Stina, please.
I want to ask a question. When I started in the neonatal unit some years ago, we were taught that if we were to cool the baby, we would start as soon as possible. I think that has changed a little bit. We are now keeping the baby in normal temperature until we really start with the critical machine, or which machine we have. And this idea and this routine to have the baby skin to skin with the parent before we start that, I don't think that many units have even thought about that idea. What do you think?
So we didn't think about it. And then my first study was about asking parents what they needed, and they can tell that they need to be close. And then we started to think, what can we do? So one thing is I mean, we have 6 hours, and it shouldn't be delayed, but sometimes we need to prepare, and there is some time gap that we can put the baby skin to skin, even if it's only like 10 or 15 minutes, because we believe that having your warm, even though it's sick and maybe intubated or anything, but having your warm maybe on your chest instead of, I mean, before the treatment, instead of waiting 3-4 days, must be a difference. So it motivates us to do that.
Yes. Thank you very much for sharing your presentation. Thank you. Our next speaker is also from Uppsala. It's Veronica Starke, a specialist nurse and also PhD student on attitudes and experience among Swedish NICU nurses on skin-to-skin care of infants born at 22 to 23 weeks. Ah, you're there. Wow. Welcome.
Hi. Do you hear me?
Yes.
Yes, good. So my name is Veronica Starke, and thank you very much for letting me participate through Teams. I unfortunately have a pneumonia right now, so I couldn't be in Stockholm. But I will still do this presentation. So I'm a pediatric registered nurse and a PhD student at the Institution of Women and Children's Health at Uppsala University in Sweden. And today I will present to you an unpublished study, Attitude and Experiences Among Swedish NICU Nurses Regarding Skin-to-Skin Care of Infant Born in Week 22 to 23. Next slide. So brief background, there's a lot of evidence that skin-to-skin have positive effect for both the children born premature and for the parents, as we heard earlier today as well. And also evidence that the earlier skin-to-skin care is initiated after birth, the more and the longer time the child receives skin-to-skin care during the remaining stay at the hospital. And as we also heard this morning, WHO updated the recommendations about KMC and IKMC in November 2022. And they say that KMC is recommended as a routine care for all preterm or low birth weight infants and should be started as soon as possible after birth. And they do not express what minimum age that is for. So how does it look in Sweden today? Next slide. You see in the upper picture is just, taken from a study by Agnes Linné et al., which shows the initiation and the duration of the skin-to-skin care for children born before 28 weeks. And each line represents different centers in Sweden. And the lower figure is from the Swedish neonatal quality register in 2020, showing children born before 25 weeks in initiation and duration during the first month. And here you can see that it's the differences between different NICUs and that we're doing some different. So the aim, next slide. The aim of this study was to investigate NICU nurses' attitude and experiences of skin-to-skin care in extremely premature infants born at 22 to 23 weeks gestation. Next. We sent out a web survey in spring 2022 to registered nurses and assistant nurses that I will now call NICU nurses. And we sent that to the 6 hospitals in Sweden that care for babies born in 22 to 23 weeks, the first period in life. And next slide. Now I will present to you some results that we have from the study. One question was, written guidelines exist about skin-to-skin care for infants born in week 22 to 23 at my NICU. And here you can see the responding staff number, all NICUs together, and each NICU is separate. And next. I think, yeah, exactly. You can see that 5 NICUs said out of 6 that they have this kind of guidelines. But you can also see big differences between the staff knowledge about these guidelines or how well spread they are. And another question was, regardless of written guidelines, we have good routine and practice about skin-to-skin care for infant born in week 22 to 23. And here, if you take next. yeah, you can also see big differences in what the staff thought about their routines. So next. We have a group that actively are working with developing skin-to-skin care. And next. Here you can see big differences in the staff's knowledge about this group or how well implemented this group is in the NICU care. So next. Yeah, so there you see the differences. It happens at my NICU that that persons other than the infant's parents perform skin-to-skin care with infant born in week 22 to 23. And next, you see here a big differences in and a large variation in how routines around having significant others involved in the skin-to-skin care for children born at 22 to 23 weeks. Next. How common is it that infants born in week 22 to 23 are cared for skin-to-skin during the first week of life? And you can do 2 clicks here. Yes, so I compared 2 different NICUs here. There you can see the largest number of answers will have been at very unusual, and on the other, it is uncommon. So you see the big differences in how common this is in different NICUs for skin-to-skin care the first week of life. Next. What is quite similar in Sweden, though, is how difficult do you think it is to provide skin-to-skin care for infant born in week 22 to 23? Here we are thinking quite similar, and you can see if you put next that we are somewhere in the middle, neither difficult or easy. So quite a Swedish approach to this. Next. I will also show you some qualitative results, and then we find out these main themes, possibilities, and challenges to provide skin-to-skin care for this group of children, and I will give some quotes under each sub-theme. Next. More stable ventilation and circulation for the child, better early attachment mother-child. Next. So benefits for the parents. Parents become involved and have an easier time bonding with their child. Something positive for both. And that you set a routine for the remaining care, that child well-being is the best when it's skin-to-skin. It becomes a norm. Next. The staff's roles and promoting way of working was also a possibility. Well-designed nursing room with space for a raised and lowered parental bed facilitate the care of the child. Single room which give peace and quiet. Next. There was also some challenges. Routines and guidelines and way of working. Sometimes it is difficult to provide the same care regardless of which staff is working. Difficult when there is no written routine. Next. The child's and the parents' conditions could also see as a challenge. There are too many risks. Tapes of probes, tubes, umbilical catheter do not always fit optimally. Brain hemorrhage is a risk during the first week of life. Loud noises, rapid movements can contribute to it. Next. The staff approach was also a challenge. I think there's a lack of evidence for these tiny and immature children and skin-to-skin care. If I had, I would have been able to justify more why we should be careful these little children's skin-to-skin. Then more children would have come out earlier. Next. So to sum up this study, there is a large variation in the NICU nurses' attitude and experiences regarding skin-to-skin care. And NICU nurses' attitude and experiences are of great importance for information on helping parents for their child to proceed skin-to-skin care. The NICU nurses expressed a strong motivation to provide the best care they can for the children and the parents they are meeting. But there is some lack of knowledge that controls the actions and assumptions about what is the best care. So we have a lot to learn from each other. And next slide. Thank you.
Thank you so much, Veronica. I think it is evident that the attitudes were very different. And what do you think is what is the next step? What kind of knowledge do we need first?
Well, I think that to change the attitudes, maybe we need to spread the knowledge and maybe spread some tricks to help the NICU nurses to provide more skin care, but also how evidence knowledge is spread in the NICUs, because it seems like there was lack of knowledge that's also stop skin care from happening.
Yes. I'm standing here thinking about whether we at all know at that gestational age what happens in the brain when we give this sensory information. I'm not sure we know, actually. Any more comments? Stina?
Yes. Or is it the other way around? We don't know what happens when this sensory stimulation we do when we put them in the incubator. Maybe they can be only skin to skin and no transfer back sort of into the incubator.
So, again, we don't know. So, yeah. Okay, I think there are no more questions here. No. Thank you very much. Very important work, Veronica.
Thank you.
Our last speaker is Kajsa Brimdyr. Welcome.
Hi.
I Googled you and I saw that you are an ethnographer and a PhD.
Yes.
And you have to tell us what is ethnographer.
So I am a PhD researcher. I finished my PhD, unlike many of my colleagues here, 25 years ago. So, and what I'm interested in is how people work and what does it really look like. And so an ethnographer is interested in looking at the work that is being done in context. And so often we think about what are the routines, what are the guidelines, what are the protocols, and that is often very different from what is actually being done. And so one of the things I'm really interested in is what is actually happening. And I got stuck on skin to skin in the first hour after birth. And specifically, I'm a video ethnographer, so I'm very interested in using video to look at what is happening during that first hour. It's such a busy time, and there's so many things happening, that one of the things that can really help us is doing video ethnography, because then we can record it and go back and look at it later and say, what actually happened during that time? I know there were so many things, but what were the barriers? Because our thoughts about what the barriers were, and then when we look at the video, what the barriers actually were, they often don't match. And so video ethnography can help us understand what those barriers are and also help us celebrate what went well, what was good.
So we have some new methodology to
Yes, it's a really fun methodology.
Okay, so you're going to talk about the 9 stages of instinctive behavior for preterm infants.
Yes, so specifically I had been looking at the 9 stages. Niels talked about them for just a brief moment this morning, the 9 stages of full-term infants, and we have been studying them for years and years and years. We know so much about those 9 stages that full-term babies go through during the first hour after birth when we put them skin to skin. And it's so incredible, and it's one of the beautiful things about video ethnography is that you get to videotape it and then watch them. And you can watch their tongues, and see how their tongues change during that first hour. You can watch their fingers and go back and look at that. How are these different babies influenced or changed? And one of the things I'm really interested in is what labor medications did the mother get? And how does that change the way the baby behaved during the first hour after birth? Because there's so many things we can look at, but looking at the baby is one of the really nice ways of sort of understanding what's going on there. But as you said, we are talking today about premature infants, not about full-term infants. And the funny thing about premature infants is that they're also babies. They are. Which means that when we put them skin to skin, they will still go through those 9 stages. It just might take them a little more time. So instead of giving them only an hour, we might need to give them a couple hours, or a couple days, or a couple weeks, maybe a couple months. We have to give them more time, but when we put them skin to skin, they will go through those same 9 stages. So this is a paper that we published talking about it in theory, really connecting the dots with a theory about the fact that full-term infants go through these stages. We know that the fetal development happens in the same order that those 9 stages happen. Those same behaviors are developed in the fetus in that same order. And we published a paper about that in Human Development. And then, of course, it still happens for these preterm infants as well. So, as I was saying, during the first 12 weeks, the fetus will go through these same stages in that same order. So by the end of 12 weeks, the fetus has learned how to do these things. That means by the time the baby is born, when they're 23, 24 weeks old prematurely, 26, 28 weeks old, they have been practicing these behaviors. They know what to do. And I'm jumping ahead because I was so excited to tell you this. So this is that paper that you can take a look at and look at the development of the fetus and how it connects to the 9 stages that are done by the full-term infants in that same order in the first hour after birth. And connects to 9 stages. I obviously didn't look at that. And with Anne-Marie Rydström and Christine Svensson and Eva Nissen and our whole team here, we've done many, many different papers about the importance of those 9 stages and the clinical practices that can encourage these behaviors. And this is what it looks like for the full-term infants. So we have the birth cry, relaxation, awakening, activity, rest, crawling, familiarization, suckling, and sleeping. And full-term infants, when they're placed skin to skin, will go through these behaviors. And if they don't, then we're worried about them. If they don't, it gives us an easy, quick, immediate way of saying, let's take a closer look at what's going on with that baby. I'm going to skip this. This is all the advantages of skin to skin in the first hour after birth. But let's get to preemies. So, I'm going to skip this too. Importance of kangaroo care. This is a whole room full of people who knows all of this stuff. Guess what? It's a really, really good idea. All right, so here in Sweden, we have been filming, let's bring this up, the 9 stages with premature infants. And what is fantastic is that you don't need to find a lot of baby actors. Really, all you have to do is take premature babies and put them skin to skin and record what they are doing, and they will do these 9 stages. This is what they want to do. And if we separate them and put them back together again, they start at the beginning. They usually start by crying a little bit. And then they'll relax very still. And then their hands will come out very small and still and just little motions and then larger motions. And it is absolutely amazing to watch. So let's watch a really quick video about what this looks like. Is it going to just start? Anybody know?
Yeah, coming right on you. Oh, you're dramatic. Hi, baby. You're little. Second. Congratulations. It's okay, I got it. You got it? It's a lot faster than I thought. Yeah.
So aren't they amazing? They're so incredible. And one of the nice things about thinking about what babies are doing when they're skin to skin, especially premature infants, is that when we have those 9 stages to think about, there's so many opportunities for success. Every day your baby is doing something amazing. Every day you're moving forward along those steps. It isn't only, oh, is he suckling yet? How many times, how much milk transfer? Oh, we haven't gotten there. Because every time they move their hands, oh, that's awakening. Oh, that's activity with more hand motion. And familiarization is a long stage for full-term infants. It takes 20 minutes. So for the premature infant, when it might take days and weeks, that's all of that licking and nuzzling and shaping the nipple. And when every piece of that is valuable, not just the did they suckle, it really gives us so many more opportunities to be excited and to celebrate. So, and thank you. This is my favorite thing to talk about in the whole world. So if you want to talk about that more, come find me. But thank you for giving me an opportunity.
Thank you, Kajsa. That was beautiful, really. Questions?
Yeah,
please.
I'm Nick Konneman from the Netherlands. I've heard you before in Leeds when you were talking about the full-term babies, so I'm delighted to see you again. Thank you for coming. And you actually taught me something today, because I'd never ever thought to transfer the 9 stages to the preterm infant. So I really like to congratulate you on that. It's really amazing work.
It's incredible that we don't think about them as being babies in the same sense. So
yeah,
it's really...
we actually call the different stages of, in the Dutch language, we alliterate, like snuffelstage. It's like sniffing at the breast, and then we have nipple training.
Yeah.
It's the familiarization of the nipple. And so those are the only 2 stages that we thought of.
Yeah, exactly. But to expand them out, to really celebrate.
I think it's really important to bring this work to our NICUs, because a lot of people there are so focused on supporting the baby to come to the breast. And your work actually tells us that the baby can do it himself.
Right.
So thank you for this.
Yeah, thank you. So exciting. Babies are amazing. Well, and also there's something about seeing it. What we saw with the full-term infants is that when we saw it, when we filmed it and saw it and shared it with the magical hour, shared it with practical advice, people could change their practice, not just because they were being told to, but because they could see what the baby was doing, which of course the babies had been doing, but we didn't see them. And I think that's the same thing here. We've been telling our colleagues, we've been saying that this is happening, but when you can point to it and say, oh, see the baby's tongue? Oh, that's so important. Let's talk about the baby's tongue for a moment. Or see the hand motion, that we can value so many more steps along the way, and that can help them, our colleagues, also see and value the skin-to-skin in a different way.
This was fantastic. We, in Sweden, many units use the Kerstin Hedberg Nyqvist, the wheel of breastfeeding for preterm babies. Maybe we could put these behaviors into this wheel also to remind people about, to look for these signs and behaviors in the baby.
Exactly. In the clinical practice article that I put up earlier, we specifically talk about how it connects to that wheel, because that wheel is so important and so ingrained in the history of looking at all of this. But it's sort of a little bit bigger, because the wheel is so focused on the breastfeeding piece. And at least in the US, we can't do too many things that focus only on breastfeeding, because it leaves out so many of our formula feeding moms. And yet, by looking at it this way, we're talking about the baby's behavior. There's so many other pieces to it. And then when the baby, oops, self-attaches, so many times parents have said, oh, well, that was sort of easier than I thought. Or, well, if he really wants to breastfeed, I guess I could do it for a little while. But it's such a nice way of bringing it beyond just breastfeeding. So it's about the instinctive behavior instead of only, we need to get that baby nursing.
Yes, I have a question. Ulrika from neonatology again. Yes, what do you think is the effect when they are given this opportunity versus when they're not given the opportunity?
Well, that'd be a great research study. If only we had a research study that was happening about immediate skin-to-skin. So I think there are research studies that are being done and public papers that are being published that are talking about how important it was, that we've been hearing about already today, to put those babies skin-to-skin. For me, seeing it, the stages anyway, really helps put it in context both for the parents and for the staff. For the staff, it gives it more value. Oh, the baby's actually doing something. It isn't just, oh, another hour of skin to skin. How many hours are they going to have? And for the parents, it gives them something to say, my baby's getting better. It might not just be one more day. I can see improvement in my baby for this moment. And we know that confidence is such an important game that we are playing with our parents. And we heard that this morning with how their confidence increased and how important that was. But great, let's do more research studies.
Yes, because I'm thinking when it comes to the full-term baby, you could see an effect in latching and not having so many complications maybe when it comes to, but I'm thinking this could be a really big thing for the premature baby to be able to make this journey in their own pace. So maybe it could have like on cognitive and so I'm thinking it takes a lot for the staff also to go on this journey, not to just put on to make it fast forward.
Exactly, and we know for full-term infants the negative impact of screwing that baby on, that the forceful hands-on latch really has a lot of negative consequences in the community and out for the baby and the parents later. So what kind of influence does us screwing the preterm baby on have on their breastfeeding compared to self-attachment, the baby doing it when they're ready, when they're done, when they're licked and nuzzled, and yeah. So more research studies to be done. Really important.
Thank you so much.
Thank you.
Very inspiring. Okay, so in this session we have heard about delivery room cuddling, skin-to-skin parental experiences, staff's attitudes to skin-to-skin in the tiniest babies, and the natural journey to sucking in preterm infants from an ethnographer. And it's really amazing to see how this field expands every year. And I think back of a book I read about when I was a medical student. I think many of you Swedish people know Johan Cullberg, a Swedish psychiatrist and psychoanalyst. And he talked about that when a woman is pregnant, she creates her mental room for the child. Already in pregnancy, we've heard from Niels previously today about the MR studies showing that a pregnant woman's brain will never be the same again after the pregnancy. And she needs to protect that mental room in having no separation. And I think that we have learned that the next steps for promoting closeness and implement is to implement it in the smallest babies, in the sickest babies, to promote breastfeeding, and also, which I'm very interested in the post-discharge process to promote the parent-infant interaction. So always together, and have a nice fika.